ACLS Certification Practice Exam, 59 questions, test. Question 1. Which type of atrioventricular block best describes this rhythm, characterized by constant PR intervals with intermittently dropped QRS complexes? First degree AV block. Second degree type I, Wenckebach. Second degree type 2, Mobitz 2. Third degree AV block. In second degree AV block type 2, the PR interval remains constant, but some P waves are not followed by a QRS complex, indicating a block below the AV node. Question 2. Your patient is in cardiac arrest and has been intubated. To assess CPR quality, which should you do? Monitor the patient's PETCO2. Check for a carotid pulse during compressions. Monitor the heart rate on the ECG. Perform a finger sweep for obstructions. PETCO2, capnography, is a reliable indicator of CO2 being delivered to the lungs, reflecting the quality of chest compressions and cardiac output during resuscitation. Question 3. Which facility is the most appropriate EMS destination for a patient with sudden cardiac arrest who achieved return of spontaneous circulation, ROSC, in the field? Nearest community hospital, children's hospital, psychiatric facility, coronary reperfusion capable medical center. Post-cardiac arrest care requires specialized interventions, including PCI, percutaneous coronary intervention, and targeted temperature management, usually found at specialized centers. Question 4. Which of the following signs is a likely indicator of cardiac arrest in an unresponsive patient? Loud snoring, rapid, shallow breathing, agonal gasps, controlled deep breaths. Agonal gasps are an abnormal pattern of breathing and are often a sign of early cardiac arrest. They should not be mistaken for normal breathing. Question 5. Which type of atrioventricular block best describes this rhythm, characterized by a PR interval that progressively lengthens until a QRS is dropped? First degree atrioventricular block. Second degree atrioventricular block type I. Second degree atrioventricular block type 2. Third degree atrioventricular block. Second degree AV block type I, Wenckebach, features a progressive prolongation of the PR interval until a P wave fails to conduct to the ventricles. Question 6. To properly ventilate a patient with a perfusing rhythm, respiratory arrest with a pulse, how often do you squeeze the bag? Once every 2 to 3 seconds. Once every 5 to 6 seconds. Once every 10 to 12 seconds. Once every 15 to 20 seconds. For an adult in respiratory arrest with a pulse, rescue breathing should be provided at a rate of 10 to 12 breaths per minute, or 1 breath every 5 to 6 seconds. Question 7. In addition to clinical assessment, which is the most reliable method to confirm and monitor correct placement of an endotracheal tube? Auscultation of the stomach, pulse oximetry, continuous waveform capnography, chest X-ray. Waveform capnography is the gold standard for confirming ET tube placement, as it detects CO2 exhaled from the lungs. Question 8. You are caring for a patient with a suspected stroke whose symptoms started 2 hours ago. The CT scan was normal, no hemorrhage. The patient has no contraindications to fibrinolytic therapy. What is the best treatment? Observe for another 2 hours. Start fibrinolytic therapy as soon as possible. Administer 325 mg of aspirin only. Wait for a neurologist to arrive. Fibrinolytic therapy, TPA, should be administered as soon as possible within the 3 to 4.5 hour window for patients with ischemic stroke. Question 9. Which best describes a rhythm with no relationship between P waves and QRS complexes? First degree block. Second degree type I. Second degree type 2. Third degree atrioventricular block. In third degree, complete AV block, the atria and ventricles beat independently because the electrical impulse from the atria is completely blocked. Question 10. What is the recommended range for targeted temperature management after cardiac arrest? 30 to 32 degrees Celsius, 31 to 33 degrees Celsius, 32 to 36 degrees Celsius, 35 to 37 degrees Celsius. Post-arrest targeted temperature management, TTM, should select and maintain a constant temperature between 32 degrees Celsius and 36 degrees Celsius for at least 24 hours. Question 11. Which is the recommended first intravenous dose of amiodarone for a patient with refractory ventricular fibrillation? 150 mg 1 mg per kilogram, 200 mg 300 mg. The first dose of amiodarone for pulseless VF or VT is a 300 mg for/IO bolus. Question 12. What is the primary goal of a medical emergency team, MET, or rapid response team, RRT, to handle hospital billing? Improving patient outcomes by identifying and treating early clinical deterioration, to perform routine physical exams, to assist with elective surgeries. RRTs are designed to intervene before a patient suffers a full cardiac or respiratory arrest by recognizing early warning signs of decline. Question 13. What is the recommended next step after a defibrillation attempt? Check for a pulse immediately. Analyze the rhythm. Wait for 30 seconds for the shock to work. Resume CPR, starting with chest compressions. Immediately following a shock, CPR should be resumed for 2 minutes, 5 cycles, before the next rhythm check to minimize pauses in perfusion. Question 14. Which critical action by the EMS team will expedite care for a suspected stroke patient on arrival? Filling out insurance paperwork, stopping for fuel, alert the hospital, determining the patient's diet history. Pre-arrival notification allows the hospital stroke team to prepare resources, like the CT scanner, before the patient arrive, reducing time to treatment. Question 15. A CHF patient has shortness of breath, BP 68/50, and HR 190. How is this rhythm categorized? Stable tachycardia, sinus rhythm, bradycardia, unstable supraventricular tachycardia. A heart rate of 190 with signs of hemodynamic instability, low BP, respiratory distress, is classified as unstable supraventricular tachycardia. Question 16. Your team finds a 59-year-old man unresponsive on the floor. Which is the next step? Call the patient's doctor. Check the patient's breathing and pulse. Apply a cold compress to the forehead. Search the house for medications. The BLS assessment sequence for an unresponsive victim involves simultaneously checking for breathing and a pulse for no more than 10 seconds. Question 17. Which best describes the length of time it should take to perform a pulse check during the BLS assessment? 2 to 5 seconds, 5 to 10 seconds, at least 15 seconds, up to 30 seconds. The pulse check should take at least 5 seconds but no more than 10 seconds to avoid unnecessary delays in starting CPR. Question 18. You instruct a team member to give 1 mg atropine 4. Which is the best example of closed-loop communication? Okay, I'll do that. Atropine is a good choice. I'll draw up 1 mg of atropine. I'm looking for the medication drawer. Closed-loop communication involves the receiver repeating the specific task assigned to confirm they heard and understood it correctly. Question 19. What is an effect of excessive ventilation during CPR? Decreased cardiac output, improved oxygenation to the brain, lowered intrathoracic pressure, increased venous return. Excessive ventilation increases intrathoracic pressure, which impedes venous return to the heart and significantly decreases cardiac output. Question 20. If a team member is about to make a mistake during resuscitation, what should the leader do? Wait until the code is over to discuss it. Ignore it to avoid hurting their feelings. Address the team member immediately. Ask the patient's family for their opinion. Resuscitation involves life-saving interventions. If an error is about to occur, it must be addressed immediately and professionally to ensure patient safety. Question 21. Which rhythm is characterized by wide QRS complexes that all look the same at a rate greater than 100 bpm? Monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, atrial fibrillation, ventricular fibrillation. Monomorphic VT presents with a rapid, regular rhythm with wide and uniform QRS complexes. Question 22. For a STEMI patient, what is the maximum goal time for ED door to balloon inflation for PCI? 30 minutes, 45 minutes, 60 minutes, 90 minutes. The national standard for door to balloon time in patients undergoing primary PCI for STEMI is 90 minutes. Question 23. Which is the maximum interval you should allow for an interruption in chest compressions? 10 seconds, 20 seconds, 30 seconds, 60 seconds. Interruptions in chest compressions, for rhythm checks, etc., should be kept to a maximum of 10 seconds to maintain coronary perfusion pressure. Question 24. Which is one way to minimize interruptions in chest compressions during CPR? Wait to charge the defibrillator until after the rhythm check. Perform a pulse check every 30 seconds. Only do compressions when the patient moves. Continue CPR while the defibrillator charges. CPR should continue while the defibrillator is charging to minimize the pre-shock pause and maximize the chance of successful shocks. Question 25. Which action should the team leader take to avoid confusion and inefficiency? Perform all tasks themselves. Let everyone choose their own role at random. Clearly delegate tasks. Avoid giving any specific orders. The team leader should assign specific roles, compressor, airway, monitor/defibrillator, to qualified team members to ensure smooth operations. Question 26. Which is an acceptable method of selecting an appropriately sized oropharyngeal airway, OPA? Measure from the corner of the mouth to the angle of the mandible. Measure from the tip of the nose to the earlobe. Use the patient's thumb size as a guide. Pick the largest one available. A correctly sized OPA is measured from the corner of the mouth to the angle of the mandible, jawbone. Question 27. A patient has chest discomfort, BP 92/50ths, and HR 92. Which assessment step is most important now? Asking about family history, checking a blood sugar, obtaining a 12-lead ECG, ordering a metabolic panel. In any patient suspected of acute coronary syndrome, ACS, obtaining and interpreting a 12-lead ECG is the priority to identify STEMI. Question 28. A patient in respiratory distress with a BP of 70/50ths has an unstable SVT rhythm. What is the treatment? Vagal maneuvers. Performing synchronized cardioversion. Amiodarone 150 mg for defibrillation. Synchronized cardioversion is the immediate treatment for patients with unstable tachycardia, SVT, AFib, aflutter, or VT with a pulse. Question 29. During post-cardiac arrest care, what is the recommended duration of targeted temperature management, TTM? At least 12 hours, at least 24 hours, 48 to 72 hours, 1 week. Once the target temperature range is reached, it should be maintained for at least 24 hours for neuroprotection. Question 30. Capnography shows a persistent waveform but a PETCO2 of only 8 mmHg during CPR. What does this indicate? The tube is in the stomach. The patient is waking up. Chest compressions may not be effective. The patient has achieved ROSC. A PETCO2 below 10 mmHg during CPR indicates that either the quality of compressions is inadequate or the patient is unlikely to achieve ROSC. Question 31. Which is the recommended oral dose of non-enteric-coated aspirin for suspected ACS? 81 mg 100 to 150 mg 160 to 325 mg 500 to 650 mg. The standard dose for ACS is 162 to 325 mg, which should be chewed to ensure rapid absorption. Question 32. A team member is assigned a task beyond their scope of practice. What should they do? Try to do it anyway. Ask for a new task or role. Ignore the assignment and walk away. Tell the leader they are too busy. ACLS team members must recognize their limitations. If assigned a task they are not qualified for, they should immediately inform the leader and ask for a different role. Question 33. As the team leader, when do you tell the chest compressors to switch? Every 5 minutes. About every 2 minutes. Whenever the compressor feels tired. Only if the compressions look shallow. Compressors should rotate every 2 minutes, or every 5 cycles of CPR, to prevent fatigue and ensure high-quality compressions. Question 34. What is the recommended compression rate for adult resuscitation? 60 to 80/min 80 to 100/min 100 to 120/min 120 to 150/min. Chest compressions should be performed at a rate of 100 to 120 compressions per minute. Question 35. A team member thinks he heard an order for 500 mg amiodarone 4 in a noisy room. What is the best response? I'll give it right away. That sounds like too much. Wait, did you say 50 mg? I have an order to give 500 mg of amiodarone 4. Using closed-loop communication to repeat the order allows the leader to hear and correct the dose. Standard dose is 300 mg, before it is given. Question 36. A patient in stable SVT is refractory to the first dose of adenosine, 6 mg. What is the next dose? 6 mg 12 mg 20 mg amiodarone 300 mg. The second dose of adenosine is 12 mg rapid for push if the first 6 mg dose does not convert the rhythm. Question 37. A patient has a witnessed loss of consciousness and the monitor shows ventricular fibrillation. What is the treatment? Atropine 1 mg CPR for 10 minutes before shock. Defibrillation. Adenosine 6 mg. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, private, are shockable rhythms requiring immediate defibrillation. Question 38. Which test should be performed for a suspected stroke patient within 25 minutes of arrival? MRI of the spine, standard abdominal ultrasound, complete thyroid panel, non-contrast CT scan of the head. The primary goal is to obtain a non-contrast head CT within 25 minutes of arrival to rule out intracranial hemorrhage. Question 39. What is the target systolic blood pressure for a hypotensive patient after ROSC? At least 80 mm Hg, at least 90 mm Hg, exactly 120 mm Hg. No minimum is required. Post-ROSC care involves maintaining a systolic BP of at least 90 mmHg or a mean arterial pressure, MAP, of at least 65 mmHg. Question 40. After 2 minutes of CPR, the rhythm is P, no pulse, and 4 is in place. What do you do next? Defibrillate at 200 J, perform synchronized cardioversion. Give epinephrine 1 mg 4. Give atropine 1 mg 4. Epinephrine 1 mg should be given as soon as possible for non-shockable rhythms, P/asystole, and repeated every 3 to 5 minutes. Question 41. A patient presented with chest pain and then went into arrest. What is the suspected cause? Acute coronary syndrome, drug overdose, drowning, electrolyte imbalance. The initial presentation of chest pain strongly suggests ACS, myocardial infarction, as the primary cause of the cardiac arrest. Question 42. In addition to defibrillation, which intervention should be performed immediately? Wait for lab results. Administer high-dose steroids. Chest compressions. Apply cooling blankets. Resuscitation from VF/private requires a combination of immediate high-quality chest compressions and early defibrillation. Question 43. Despite 2 shocks, the patient remains in pulseless VF. Which drug and dose is given first? Amiodarone 150 mg, epinephrine 1 mg, lidocaine 100 mg, vasopressin 40 units. In the pulseless arrest algorithm, epinephrine 1 mg is the first drug administered, typically after the second shock. Question 44. Despite epinephrine and continued CPR, the patient remains in VF. Which drug is next? Atropine 0.5 mg, adenosine 6 mg, dopamine 5 mcg/kg, amiodarone 300 mg. Amiodarone, 300 mg bolus, or lidocaine is administered for VF/private that is refractory to shocks and vasopressors. Question 45. The patient has ROSC but cannot follow commands. What is the immediate priority? Initiate targeted temperature management. Discharge to home. Administer oral glucose. Apply a heating pad. Targeted temperature management, TTM, is the only intervention shown to improve neurological outcomes in post-ROSC patients who are comatose. Question 46. If the patient had a pulse and tachycardia with chest pain, unstable, before the arrest, what was the priority? Vagal maneuvers. Epinephrine 1 mg, adenosine 6 mg performed synchronized cardioversion. Synchronized cardioversion is the standard treatment for unstable patients with a pulse and a tachyarrhythmia. Question 47. A patient presents with a rapid pulse and low BP. Which ACLS algorithm applies? Bradycardia, tachycardia, asystole, stroke. The tachycardia algorithm is used for patients with a heart rate typically greater than 150 bpm and a pulse. Question 48. A patient's pulse oximeter shows 84% on room air. What is the first action? Administer a sedative. Obtain an ABG. Apply oxygen. Perform a tracheostomy. Oxygen should be applied to patients with SpO2 less than 94% to maintain adequate oxygenation. Question 49. After assessment, the patient is determined to have unstable tachycardia. What is the next step? Synchronized cardioversion, amiodarone infusion, beta blocker administration, vagal maneuvers. For symptomatic/unstable tachycardia, synchronized cardioversion is the immediate treatment of choice. Question 50. If a tachycardia rhythm remains the same but the patient loses their pulse, what is the priority? Synchronized cardioversion. Give 2 liters of fluid. Start a dopamine drip. Perform defibrillation. If the rhythm is VF or pulseless VT, the priority shifts from synchronized cardioversion to unsynchronized high-energy shocks, defibrillation.